About in 30 seconds.
Well, hello everyone. Good morning or afternoon, evening, depending on where you are. I'm really excited and happy to welcome you to this webinar of the Lancet Citizens Commission on Reimagining India's Health System. I'm Sapna Desai. I'm an associate at the Population Council in Delhi and also a commissioner on the Lancet Commission. So for those of you who may not know, the Commission is a fairly ambitious and cross-sectoral endeavor that we're aiming to lay out a people's roadmap, a citizen's roadmap to achieving universal health coverage for the people of India. It is both a research effort, an effort consulting people across the country in different parts of the health system, as well as bringing together key stakeholders to really think through different roadmaps for different stages of UHC in India. So we have this monthly webinar series that is served, we've had a few already, that's been a great platform to just engage in public health discourse in the country. And it's been a great way to bring in experts studying universal health coverage across the country to engage in debate, of course, with us, but with a much wider audience. So thank you all for joining. I see a lot of you here already. So today's webinar is on a study titled Health Seeking Behavior in 4 Indian States. It's being conducted by the Nossal Institute for Global Health at the University of Melbourne with the National Council for Applied Economic Research, NCR, and the Population Council in India with me. The study is conducted across 8 districts in 4 states of the country. Before I begin introducing our amazing speakers today, I just wanted to remind you there's a little survey at the end of the webinar. We'd love to hear your thoughts both on future webinars as well as this one's. And of course, you can sign up. We'll put the Commission's website in the chat if anyone would like to receive our newsletter. So now I'm going to introduce you to our speakers and panelists. So we'll be hearing about the study from Professor Barbara McPeak and Sumit Gane, both at the Nossal Institute. So Professor Barbara McPeak is a chair of global health at the Melbourne School of Population and Global Health and director of the Nossal Institute. She specializes in health policy and health systems research with over 30 years of experience. And Dr. Sumit Gane is an associate professor and principal research fellow also at the Nossal Institute. And his work focuses on equity, quality, and responsiveness in low and middle income country societies and health systems transitioning to a post-service availability phase. So they'll be presenting the study findings to us. And we'll be joined in conversation then with 3 panelists. We have Professor Arnab Mukherjee, who's a professor of public policy at the Center for Public Policy at IIM Bangalore. He's also the founding program director there for the Mahatma Gandhi National Fellowship Program. Arnab uses administrative and survey data, particularly in the domains of spanning healthcare and development economics. He's also a commissioner on the Lancet Commission. Then we have Dr. Devaki Nambiar, who's program head of health systems and equity at the George Institute for Global Health. Devaki has over a decade and a half of research experience in many Indian states as well as other countries. And her work focuses on research and action on the social and political determinants of health and health reform. And lastly, and we're very happy to welcome Dr. Poonam Gupta, who's the Director General of NCAR. And before joining NCR, which was fairly recent, she was lead economist of global macro and market research at the International Finance Corporation, lead economist for India at the World Bank. She's also been, I'm sure many of you know, at the RBI chair at the National Institute of Public Finance and Policy, as well as previously at ICRIER and the Delhi School of Economics. So with that, welcome again to all of you. Thank you so much for joining us. Myself am very excited to hear first about the study and of course our panelists' views. So with that, Sumit and Barbara, I'm going to turn to you to present the study. Thanks.
Thanks. Sumit's going to share screen in the first
I'll share my screen, yes. Let me see.
It's not here yet.
Not here yet, yeah.
Fabulous.
All right.
So thank you very much, Sapna. It's a pleasure to be here talking to such a fine audience. I see we're at 72, which is very impressive. So as Sapna said, we're going to talk about healthcare seeking behaviour in 4 Indian states, but in fact, we're only so far able to talk about 2 Indian states as our fieldwork has been constrained by the COVID epidemic. So this is really a preliminary look at the first stage of our findings from this study. Next slide, please, Sumit. The partners in the study, I think, have already been mentioned. The National Council of Applied Economic Research, or NCAER, ourselves, the Nossal Institute for Global Health at the University of Melbourne, and the Population Council in India, where Sapna has been contributing from. Thank you. Next. So the central hypothesis of the work that we're doing is that stronger public health systems result in greater use of public services, shorter care paths, so fewer visits before people have reached what they are hoping to reach, a lower burden of out-of-pocket expenditure, and improved health service outcomes, both from the point of view of health outcomes, but also economic outcomes for households. The project has 4 main components, although they have subcomponents, but we've been analysing existing data sets that many of you will be very familiar with, the NSS and the IHDS. We conducted our own household survey with the aim of understanding better the full healthcare seeking journeys that people undergo. And as you know, or as many of you know, those existing data sets take a snapshot of the most recent visit primarily. And so we wanted to get beyond understanding just that most recent visit. There's a large qualitative inquiry that Sumit is going to present when we get to it. And there's also a discrete choice experiment, which we're not going to present today. We've started to analyse the data. I've got a bit stuck and can talk about that if anybody's got questions. And we're planning to do some more data collection, which we hope will help resolve the stuckness. The idea of the project as a whole is that we'll compare 2 states which we start off with the premise have low levels of health system development, and those have been selected as Odisha and Uttar Pradesh, and 2 that have better levels of health system development, Maharashtra and Tamil Nadu, but it's the 2 presumed to have low levels of health system development that we've so far been able to explore. So our 2 states that we'll be talking about will be Odisha and UP. A lot of the work that we've done, certainly for our own survey, has focused on using 3 conditions as tracers for different sets of things that may be going on in the health system. So we wanted an adult chronic condition, and there's no point in naming a very specific condition, you'll understand, because people don't necessarily have diagnoses or know what their very specific condition is. So we were interested in COPD, chronic obstructive pulmonary disease, but we recognize that people might have asthma, they might have other respiratory diseases, and they might be confusing that with COPD. So the category of people that we selected were those that have chronic respiratory complaints. Chronic means a period longer than 6 months, and the symptoms are consistent with COPD, and the criterion for considering them serious, not just the odd slight cough, is that you might ordinarily seek care to resolve them. The second condition are common gynecological complaints, and this is really women reporting a range of problems such as abnormal heavy bleeding, abnormal vaginal discharge, And again, this criterion, severe enough to contemplate treatment. And we also wanted a condition to pick up children in the health-seeking behaviour situation. And so we chose acute respiratory infection there, defined as suffering from severe cough, high fever, difficulty in breathing, and again would normally suggest the need for care. Thanks. Next slide, please. What we've done so far is we've analysed the existing data sets, we've completed that analysis and published it, so I'll talk about that. We have done the household survey in 4 districts in the first 2 states, as I described. We've completed the qualitative inquiry, which we've just done in UP and Maharashtra. Actually, I should have said that at the beginning in saying that we were only talking about 2 states. The quantitative work has been done in UP and Odisha, and the qualitative work has been done in UP and Maharashtra. So we have picked up issues of what we presume to be a better functioning health system in Maharashtra there. And we have, as I said earlier, we've collected discrete choice experiment data, but our analysis is not complete. Thanks. Next slide, please. Just quickly to let you know which districts we went to in the 2 states, in Uttar Pradesh, Firozabad and Chandauli. All the districts that we've selected were selected based on having median health system indicators for the state, and in Odisha, Bargarh and Dhenkanal. Thank you. Next slide. So, launch into findings. First of all, as I said, the secondary analysis of the data, which is complete and as I said, published. The question that we asked of the secondary data is there an association between public spending on health and choice of healthcare providers across socioeconomic groups in India, and looking specifically at the relationships between state level public spending and, first of all, the decision of whether to seek care or not. Secondly, on the choice of medical provider. And then thirdly, we've asked whether these relationships are different for the different socioeconomic groups. And for this analysis, we've used the NSS 2014 data, and we have government health spending data from the 2016 National Health Profile report and other data from the Reserve Bank of India. Thank you. Next slide. So there are 2 regression-based approaches that we've used here. The first is a simple multi-level logistic multinomial regression for the likelihood of seeking treatment. And the second is an instrumental variable regression approach for the choice of medical provider. And the idea there is to control for the potential for endogeneity. In other words, we're interested in whether or not greater public spending causes greater use of public health services or a greater propensity to choose a public health provider, but we're wary of the possibility that more people choosing a public health provider increases health expenditure. And so the instrumental variable that we used for that is the fiscal deficit, on the basis that where there's a large fiscal deficit, people using more public health services can't be responded to by increasing public health expenditure, or that's the theory anyway, and therefore that's the variable that we use to try and control for that. Next slide, please. So there is, the data show us that there's a statistically significant association between public spending on health per capita and choice of medical provider. But the choice to seek care at all is not responsive to the level of public spending on health. And that's not really very surprising, because the choice to seek care at all in the NSS is about 97% of people who consider they need it. And so it's not very likely that anything's going to push it up much higher than 97%. And to put the relationship into sort of easy to understand terms, for every increase of 100 rupees in public health spending per capita, the odds of using outpatient care at a private hospital reduced by about 5 to 10%, and the odds of using outpatient care at a private clinic reduced by about 10 to 15%. So that's a pretty significant effect of quite a small increase in health spending per capita. And we can see the easiest thing to see in this this plot is how far the private options are from 1 in the figure. So you can see inpatient private clinic, inpatient private hospital, about a 20% less chance of using if public health expenditure is 100 rupees higher, and other private options are also that side of the line. Next slide, please. And then finally, when we look at the poorest quintile compared to the richest quintile, we see that that impact is biggest for the poorest quintile. So for the richest quintile, their chance of choosing a private clinic reduces by 9% with each increase of 100 rupees per capita. And for the poorest quintile, the chance of using a private clinic reduces by 17%. Next slide. I should pass on to Sumit to talk about the qualitative results before coming back to talk about what we learned from our own survey. Thank you, Sumit.
Thank you, Barbara. We conducted the qualitative study in Uttar Pradesh and Maharashtra, and this was done across 2 districts in Uttar Pradesh and 1 district so far in Maharashtra. A bit of work is still to be done in Maharashtra. The objective was to unpack the care-seeking journeys for chronic illnesses. So here we focused on the 2 chronic illnesses, the common chronic gynecological conditions and the chronic breathlessness, because the underlying condition could be whatever, as Barbara said. We are in the final stages of preparing the manuscript, but and I'm happy to share further details with those who are interested. But we've spoken to around 65 men, women, families, if you may, over a period of, and the fieldwork was done over a period of 4 to 8 weeks across the 2 states, teams of 2 to 3 people conducting these inquiries. And the analysis is organized along the lines of and is presented here using the metaphor of a journey. And I'll come to it in a bit. We are looking at 2 broad stages in the care-seeking journey. That's how we are presenting it. That's how we are approaching this this analysis. The first stage, we're calling it the stage of running from pillar to post. It is this stage where people are desperate, people are confused, people don't know what's happening. They've just started experiencing these symptoms, quite debilitating, and this is a stage where they're not sure what is happening to them. This is a stage where they are desperate. They don't have reliable sources for information. They don't know where to go. So this is the kinds of quotes we heard. People talked about, we went to whichever doctor, whoever was available nearby. People talked about, we may have gone to at least 10 to 15 doctors. Some said hundreds, you know how it goes. This is a stage where people are looking for a cure. People are talking about getting a cure no matter what. If it is at a government hospital or a private hospital, it didn't matter. One thing that kept coming back was the idea of the hope of getting rid of the illness by its roots. And those of us who speak Hindi, Marathi, You would recognize some of these quotes. People talked about jad se nikal jaye in Hindi, that it should get out, be removed from the roots, and in Marathi, murat na nighun jawa, as we say in Marathi. What we found was that this desperation was compounded by the lack of reliable and trustworthy sources of advice and care. Trustworthy sources of advice and care close to where people were. And we found that this rendered people vulnerable to being misled down wrong paths, being exploited by unscrupulous, profiteering, and often, but not always, unqualified providers. We found that their vulnerability was amplified at the intersection of being worried, the urgency for a search for cure, the hope for cure, and interestingly and importantly, the desire to do the right thing for one's loved ones, and also the desire to be seen as doing all that is possible for one's loved ones. These are just pictures of some of the places that we found as part of our fieldwork. Many of you have seen these kinds of clinics. They're called chola chaps, as some of you might recognize. The second stage is the stage which we are calling a stage of exhaustion, a stage of reconciliation, and a stage of acceptance. And what does this mean? What all does this stage really mean? And this is what people told us. The stage of exhaustion, the stage of being broken, is exemplified by these kinds of quotes that we heard. People talked about the disease being broken them, having broken them in many possible ways. Others talked about they used the metaphor of war, and they talked about the disease having overpowered them, having been defeated at the hands of this disease. Most of this talk is related to chronic breathlessness. Most of this talk relates to dama, dam as it is called in Marathi, dama in Hindi. People talked about them having no options but to go to the local unqualified is what they meant, irrespective of the treatment they received. They talked about what else could we do. They talked about we have no choice, but we cannot go to the big cities. We have to leave everything to God, and so on and so forth. As many in the audience would recognize, those of who speak Hindi or Marathi, the word dam refers to both being breathless and to being alive. And what this gentleman was saying was that ye dam to jam ke saath hi jayega, which means that this illness I recognize that this illness will go now only with the stopping of my breath. So unlike the defeated acceptance of the early stages of the illness and the early stages of care seeking, this is a different kind of acceptance. This is the acceptance of a battle-hardened soldier who's knowledgeable about the enemy and the enemy's powers, the enemy being the illness, and recognizes that, okay, this is going to go only when he stops breathing, and so on and so forth. So this particular stage also involves the emergence of what we call a battle-hardened, experienced expert patient who is calculative, pragmatic, and focused on getting relief at his or her own convenience, and is looking for responsiveness from providers. We argue in the paper that hopefully will come out soon that this patient is focused on getting relief, and this makes the person differently vulnerable to being medically mismanaged, wrong treatments. We saw people receiving steroid injections right, left, and center, being mismanaged in terms of no attention being paid to their side effects. Again, we saw patients with serious side effects of steroids, particularly, and to treatments being administered wrongly. We found that our conclusion is that patients in this stage are looking for and actually need reliable and responsive sources of advice and care close to where they live, close to their homes. The overall study had a whole bunch of findings. We have examined the data from many different ways, but the key takeaways from the qualitative study, if you may, are the following 6. That people manage. The jugaad is the word that comes to my mind. People deftly navigate the poorly functioning and poorly regulated health system that they have to deal with. They rely on social and relational networks and resources, and those who don't have these resources are left to fend for themselves. They go down the wrong path. They are prone to being exploited. We found that the point of first call is critical. It is obvious, but we found it in a very dramatic way. It sets one on a particular path in the care-seeking journey, and that path could lead to being exploited and running into catastrophic health expenditures, or spending little and managing fine. And we also found that the poorest, those who are financially, socially, and relationally poor, are the most vulnerable. We have also found that the importance of having in place accessible, reliable, and trustworthy sources of advice at the point of call, close to people's homes, is critical. Most importantly, and finally, our findings show that when such services, such arrangements are in place, people will use them. And the final quote here kind of exemplifies it. This gentleman said, if there were better facilities provided in government hospitals, why would one go to private hospitals and spend so much money? This was a common refrain across the board, across the study sites. And this, to us, points to the importance of having strong primary care services close to where people live. I'll pass the mic back to Barbara to carry on speaking about the survey. Barbara, over to you.
Thanks, Sumit. So now we're on to our own survey. The previous findings related to the secondary data that many of us are analysing. This is our own survey, and the point of our own survey, as I said earlier, was to look in more depth at the journeys that people go on. Something which, as I'll point out shortly, was only partly successful. Anyway, we had this 2,084 households across 4 districts, and we have not yet done the work in Tamil Nadu and Maharashtra, but we do expect that to be completed quite soon. So hopefully we'll be able to come back to you soon with some updated results. This is just the big regression. What explains how much people spend on healthcare? And the significant numbers are the number of providers they go to for children and adults, the number of government providers they go to for children and adults again, the number of visits made for children and women, whether decision-making is joint between the couple or not, the average distance to providers for all 3 conditions, household size marginally significant for women and adults, religion for all conditions, monthly income, and marginally significant is the household head being male. So that's a kind of overall picture of the things that predict expenditure. I think what's most important from our point of view is that the more providers you go to, the more you spend. And that's independent of the number of visits that you make. So number of visits creates extra expenditure too. But if you go to the same number of visits with more different providers, you'll spend a total of more. And that makes sense. Every provider wants to run the same tests on you again and so on. But it underlines the inefficiencies of not having a single point of call where you know you will get what you need first time round. Next slide, please. So I'm just going to show you a series of these bar charts that are perhaps a little easier to understand than multiple regression analysis. And this first one really explains what I mean by we were only partially successful in getting these full length of journeys that we were interested in. we asked about the last flare-up of the condition rather than the last visit. So we got information for an average of about 1.5 visits. So we saw a slightly longer or slightly more ability to look at progressions. And of course, that average means that there were some cases where we saw some quite long journeys within that last flare-up. But we realized after this round of data collection that just asking about the last flare-up, when people might have had a condition for years, doesn't really capture this stage of treatment seeking that Sumit particularly captured in the qualitative work. In the early stage, when you first start to experience symptoms, when you're looking for relief from those symptoms, and especially still under the impression that you might be able to find a cure for your problem, is when your journeys are really long, when you keep being exploited by a wide range of different kinds of providers successively. And so for our next rounds, when we go to Maharashtra and Tamil Nadu, we plan to expand that question a bit to get more focus on those journeys at the beginning. The next set of slides are just a series of comparisons. This first one looking at how each of these are arranged, with the top left, the mean number of medical visits, the top right, the mean number of providers, the bottom left, the total costs, and the bottom right, the costs per visit. And this first set of slides compares the conditions in order: adult respiratory conditions on the left, gynecological conditions in the middle, and the child respiratory condition on the right. And what you can see from this is that in all cases, number of visits, number of providers, total costs, and cost per visit, the adult respiratory condition is the most expensive. And in general, the child respiratory condition comes next, and the gynecological condition comes third, although when you look at total costs and cost per visit, the differences between the gynecological condition and the child condition are not large. Next slide, please. So the second set of comparisons looks at the disease stage, comparing a history of the condition being less than 2 years in the left bar and more than 6 years in the right bar. We maybe thought we would see the opposite of what we're seeing here, particularly based on the qualitative results, that an awful lot is spent at the beginning. But I think what we're seeing here is that 6 years into the condition, it's becoming harder to manage the symptoms, and more treatment seeking is needed to keep symptoms at bay. And so we're seeing larger numbers of visits, larger numbers of providers, higher total costs, and to some extent, higher costs per visit as well. And I should say that for all these figures, we're seeing that costs are really dominated by spending in the private sector. Next slide, please. And I should say the private sector is in the pink and the public sector in the purple. Here we can compare Odisha and UP, and we can see that things are more expensive generally, and there are more visits to more providers in UP than Odisha. The costs per visit are similar. So the difference in the expenditure is driven by the number of visits. And what's also quite interesting is that in UP, the costs per visit in the public sector are scarcely lower than the costs per visit in the private sector, but people are using the public sector less, meaning that the share of total costs is much smaller. All this tends to suggest that the public sector is somewhat stronger in Odisha than it is in UP. Next slide, please. And here we compare girls and boys for the child condition. And it's quite interesting that perhaps we would have expected to see a structural discrimination against girls at every stage. But what we see is that girls are as likely to have as many visits, and that the distribution of those visits between public and private sectors are very similar. That's what we see on the top two graphs. And in the bottom two graphs, we can see that boys go to more expensive facilities. So although they're going to the same number of providers in the public and private sectors, more is being spent on boys, and that's where we can see potentially that discrimination against girls. And we also have from other data, or from the same survey, but that I'm not showing you, that boys are taken further away to find care than girls are. So there's perhaps a bit more attention paid to making sure that boys' condition is dealt with. But when we compare men and women within the same condition, chronic breathlessness, we don't see those sorts of structural discrimination against women that we might have expected. We see almost identical results throughout. So when both men and women have a problem of chronic breathlessness, the household's response is almost identical to both. That's interesting, I think, and it suggests that data that show that in general, less is spent on women, fewer visits are afforded to women, seems to operate via the taking of women's conditions less seriously, as we saw in the data comparing gynecological conditions with chronic breathlessness conditions. But when women have the same condition as men, they seem to be afforded the same resources to deal with it. It suggests the problems might be structural rather than behavioral, in the sense that they might be about the system's supply response to different conditions as much as they're about how households allocate resources. Of course, that's a question rather than a conclusion. Next slide, please. And then this is the point that Sumit was emphasizing from the qualitative work, that we can really see very clearly in the survey data. I think this is one of the major take-homes from the whole study. If you divide people by where they go first, do they go to the public sector first, or do they go to the private sector first? It makes little difference to the number of visits or the number of providers, but it makes a huge difference to it doesn't make that much difference to the cost per visit, but it makes a huge difference to the total costs of care, with the cost of care for people who first go to a private provider more than double the level of out-of-pocket spending in the end than those who first go to the public sector. And I think this underlines the point that Sumit was also making, is that if people have a trusted public sector source to go to for the initial stage of care, it will have a massive difference on the extent of economic impoverishment through health engagement, through engagement with the health system. Next slide, please. So just to conclude now, our evidence broadly supports the argument that public health expenditure supports a stronger health system that is better for households, both from the point of view of delivering what is likely more reliable healthcare, but certainly less economically impoverishing healthcare. It contradicts the arguments that one sometimes hears about investing in the public sector, that it's a kind of bottomless pit. No matter how much money you throw at it, nothing ever gets better. It seems not to be true. Those states that spend more seem to get better public care out of it, that is recognized as such by the people who are using it, who are voting with their feet and choosing it more. And especially poorer groups who are quickest to respond to better care being available in the public sector. Again, I think this is one of the major implications of the work that we've done. We do need to do more work to get better into the question of the multiple legs of the healthcare seeking journey, because we haven't got as much from the last flare up as we would hope, but we have got some interesting things, including the importance of starting in the public sector. What we learned particularly from the qualitative work, as Sumit was emphasizing, is that the early stage of care seeking for a chronic condition is particularly important. Once people have had a condition for a while, they've found a relatively affordable, stable state in which they keep going back to the same provider. They may not be getting good care from that provider, as we talked about, the massive amount of steroid use that's well beyond what would be recommended and will be causing other chronic problems in the long run. But it stops being economically impoverishing after that first phase of getting into a settled relationship with a particular provider. And I think what's really important about that first phase is that it seems to be very, very often impoverishing. Many of the people Sumit and his team spoke to were substantially economically diminished by this stage of the health-seeking journey, whether they'd sold important assets, taken children out of school. Many of these households' living conditions and economic situation were dramatically affected by the resources that, in many cases, they had wasted looking for a cure. And this, I think, is something that needs to be taken seriously at a level beyond the humanitarian concern for specific households and into the level of the economic development and the poverty strategies, the anti-poverty strategies for the country as a whole, because nearly every household will go through that stage at least once, at least in a decade. And when you think about it in those terms, this is a major economic threat to virtually all but the most prosperous, wealthy households in India, and needs to be taken very seriously at a macroeconomic and poverty reduction level, and not only, although it's very important too, at the humanitarian concern level. And then the final point to just underline is that public primary care does seem to be the measure that could make the biggest difference here. It would be available close to people to be their first point of call, could, if trusted, could provide them with the information that is critically important at that stage, that this is a chronic condition and not an acute one, that it won't have a cure, and that finding a way to live with it is necessary before huge amounts of assets are sold to try and find that cure, or children's future is compromised by losing access to education. And I think it's worth pointing out, although of course we all know that the Ayushman Bharat program is particularly aimed at strengthening primary care and widening its scope to include chronic conditions for adults, and it definitely has the potential to make a major difference if it can be successful. Thank you. Final slide is just to talk about what we're doing next. I think that's already clear, where we have plans to finish the data collection in Tamil Nadu and Maharashtra, also to do the discrete choice work there, which we hope will help clarify some of the issues in the discrete choice work. And we will be producing various publications and policy briefs out of this work beyond what's already been produced. So thank you very much.
Great, thank you so much, Barbara and Sumit. There are a bunch of questions for you that I'll come to after our panelists. Some are very specific to the methods and some are broader implications, so I can group those later. I'm first going to turn to Arnab Mukherjee. Arnab, first for your kind of broad reactions and reflections in relation to the work you already do with these data sets, of course, but also implications for the health system as a whole, and then also some of your thinking around the difference between the two states that we have seen. So over to you.
Thank you, Sapna. Let me begin by saying that I think this is a fascinating study, and the canvas is large, and I think very relevant in sort of today's sort of set of issues that sort of face the country in terms of how health as a industry, a sector, a public service delivery entity needs to be provided. And I think within the work already present, and I understand it's only partly complete, it's work in progress. So thank you for sharing this at an early phase. There lie many interesting and potentially sort of valuable directions that one can sort of take if one is thinking about the health system. Broadly, I mean, as a development economist, one of the usual things that one usually looks at is a broad metric like, what's the impact of health on, growth and things of that nature. And in that space, what I found very, very interesting is the responsiveness that you find that is there in the public system. You report that for an additional 100 rupees, which is very, very small in terms of the size of expenditure, there seems to be a response that's observable statistically in the multinomial regression models that you are sort of looking at. I found that fascinating, largely because people usually seem to think that throwing more money will have no effect, and I think you mentioned this. Where I think it would be useful from a policy perspective and a health systems perspective is to sort of, for me to see a little bit more about that multinomial sort of structure that you have, which is currently embedded, to try and relate that to different aspects of the health system. One of the questions that I sort of had, which you already answered, is that when you see this kind of an impact, that there is an uptake in utilization, there's a down shift in out-of-pocket expenditure, it would be interesting to know which part of the wealth or income distribution this is coming from. And you report that about, the impact seems to come from the poorest part of the distribution much more than it comes from the richer part, even though the richer part also benefits from the rollout. I was wondering if this might be something that you could also think of parsing out in the context of, well, is this coming from the primary health side? Is this coming from, PHC block level facilities? Is it coming from the state level facilities? I know it's difficult to parse a lot of that, but I think a little bit more information is embedded in sort of the secondary data set that you can comment on to present exactly which part of the supply system should work and be able to deliver these effects. Second thing that I found very, very sort of interesting in the regression models, I think this is, I've been counting, so this is, I think, slide 26, where you have like the set of column-wise regression models that you sort of present for children, women, and I guess adults, or is that men? I guess it's men. So what I found was the children results and the men's results were very, very similar. However, the women's results are completely different. And I think that is perhaps a reflection on sort of, an opportunity for demand programs to sort of work on trying to get women to get into healthcare. And this is very surprising, essentially, because, even today, our health system is largely a reproductive and child sort of centered health system. There really isn't very much beyond that if one goes to sub-centers, primary health centers also. So I guess perhaps this is something the qualitative side can sort of answer. I don't know, I'm not sort of trying to push more work onto your table, but I think that's something that should certainly be something very, very useful to sort of try and parse out. Finally, I sort of was looking at the data coming from your study, the primary data, and it looks like there's a very, very large presence of the private sector in UP, particularly in comparison to Odisha. In fact, just looking at UP and Odisha makes Odisha look very good, even though that might actually not really be the case. But if I look at UP, I was wondering, is this largely through formal, well-trained doctors who are giving private service, or is this also largely a preponderance of private providers who are your chola chap doctors, who would essentially be very, very, laissez-faire and unregulated, and be willing to give the patient whatever the patient wanted. And that might sort of be a place where, again, regulation may have a role to play. So, yeah, thank you.
Sorry, thanks, Arnab. I'm going to turn to Devaki first, and then Barbara and Sumit, I'll bring it back to you, if that's okay. I've noted the questions as well. Devaki, for your general reactions and also specifics based on your own work with treatment-seeking pathways would be great.
Thanks, Sapna. First of all, I'd like to convey my thanks to Barbara and Sumit for that presentation, really magisterial. And I'd started with a very modest set of comments, but now I've gotten overexcited. So Sapna, you may have to stop me at some point. As Sapna mentioned, I've been trying to understand patient care-seeking pathways for some time. And the sort of frame of reference that I'll use, and I try to restrict myself to 3 points, but the frame of reference is with a focus on what we call underserved populations. And I've been sort of looking at care-seeking pathways among internally displaced women in Tripura, health migrants seeking tertiary level care in Delhi, homeless persons in Delhi across genders seeking all kinds of care. And then also the people from the Katunaikan tribal community in northern Kerala. So this is sort of motley group of experiences is what shaped these questions. And I had 3 broad questions / reflection areas. The first has to do with models. The second has to do with care-seeking journeys themselves. And the third has to do with the key point, Sumit, that you raised about navigation and facilitation of care-seeking. So in the first point, I have an aside on slide 26, like Arnab does. I think a lot of us found that very intriguing. For me, what stood out was actually the R-squared value and the fact that it was much lower for children than it was for women and men. And I was trying to understand what that represents. Of course, an R-squared under 50% for human behavior is to be expected, but 17% for children, 32% for women, the highest, and 28% for men. So fairly similar for women and men, but different patterns, as Arnab was saying. And I was trying to understand what this has to do with the supply side, perhaps, in terms of the type of care that is even available for these seekers to access, right? Are we looking at a kind of floor effect for women? Are we looking at unsought care, for instance? But that's, one is able to explain, but actually excludes a lot of pathways, perhaps. I'm not sure, I don't have the expertise, but I'm keen to hear your reaction to how we would suss that out in terms of the other data points you have that would look at this. Some other models that look at care-seeking pathways, and I mentioned this to Barbara and Sumit earlier, include Thaddeus and Main's old model in the context of MCH and the 3 delays, which relate to sort of deciding to seek care in the first instance, then getting to the facility, which can be delayed. And then the 3rd delay is the receipt of appropriate and high quality care, right? And so then the corresponding intervention points or entry points are dealing with socioeconomic and cultural factors, looking at accessibility features of the health system, and then also the core issue of quality of care corresponding with the 3rd one. But I think, as you have pointed out, there is this pillar to post aspect of how care-seeking functions, and there is a kind of intermingling of the issue of accessibility with the issue of socioeconomic context, right? With the quality in relation to socioeconomic context. You of course see this with homeless populations and others who simply do not, who receive quality of care that they know is poor and lower than that others are receiving. So these things sort of interrelate. We tried to use the priority public health conditions framework, which lays out the socioeconomic conditions piece, Sumit, that you've also laid out, but also talks about vulnerabilities, differential exposures, differential outcomes and consequences. And where we struggled with that framework is that it doesn't, as you have, lay out actually the care-seeking pathway, which again bounces around each of these things. Different kinds of care-seeking pathways introduce different kinds of exposures. For example, if you're living on the footpath of a large tertiary hospital, you will have different kinds of exposures that can add to your health-seeking needs, right? If you're having to wait months on end for one diagnostic test, that can exacerbate your health condition itself. So there are those kinds of things. I think we have to find more comprehensive ways of explaining the complexity of what's going on. I think another intriguing point that you both raised has to do with the care-seeking journey itself. And the fact that, it appears that the public sector would, on the whole, be a more beneficial place to start your care-seeking. Why then do people start in the private sector? Our respondents in our studies in Delhi said that it's because of respect. It's because they are respected in the private sector that they're happy to go there, happy to repeat tests, to go in again and again. even receive inappropriate care, which they find out later because they are respected. And I think there might be issues of a trust deficit in the public sector that perhaps has to be remedied. Because in another study that we did in Maharashtra, it wasn't focused on vulnerable populations, but we found in that instance that people get diagnosed in the private sector and then are keen to come into the public sector because it's much more affordable than sticking around in the private sector. How do we address this trust deficit and increase the attractiveness of the public sector? I think you have some answers by way of allocation. Another, of course, is the challenge of transport, which we've tried to deal with in schemes like JSSK in terms of enabling transportation. But for Katanayakan families in Northern Kerala, for displaced Mizo women in Tripura, that's it. That's where your journey gets stuck, right? Because of conflict, because of distance, because of cost. You're just not able to make it. So I think those are some of the parts of the journey that we need to be thinking about across population groups. Finally, on the point of navigation, I think it's critical and seen across the studies that I've done that this role of facilitation is very, very important, but also vexed, right? So for homeless communities, for example, NGOs are sort of the intermediary to facilitate care seeking, but even they fall short. They have funding shortages. They have problematic relationships with this provider and that, or even with the community they serve. And so that consistency, that accountability that the state has, or that a provider has, or that even an NGO has to the citizen gets lost at times or is inconsistent. In other cases, there have been models, for instance, in Kerala, to have frontline health workers. I know there's a question on this. Frontline health workers representing the community. Great emphasis has been placed on training, but that continuous supportive supervision, that ability to access and continually keep the connection across the demand and supply sides is very, very difficult and hard to sustain. So we have to think about some solutions there. COVID has shown that there can be some innovation. For example, for homeless people, for them to get COVID tests, there was an appeal made to the Delhi government, which removed the requirement of having to show an Aadhaar card to get COVID tests. We were able to do it with COVID, but can we do it for everything? Can we do it beyond MCH? You know, those are the kinds of concerns we have. And I'll just end with this. I think for me, the theme that comes up again and again is the accountability issue of the state, of the private sector, of NGOs. And quite often when we think about that, that sort of poorest quintile or that left behind group, we're focusing very much on the idea of them being behind, but not the fact that we are leaving them behind. So when you look at that idea in the SDGs, the point is that we are leaving them behind. It's not that they're just, right? So I think thinking about those entry points is something that I look forward to hearing more in your future work. So I'll end with that. Keen to hear your reactions.
Thank you, Devaki, right on time. Barbara, Sumit, I'm going to turn it back to you first. I think there's almost a neat methodological sort of distinction in the type of questions you got. So I leave it to you to respond, and then I'll bring in the questions from the audience after.
Okay, let me lead off, Sumit, and pick up all the easy stuff and leave you with the tough stuff to deal with. How's that? I think, you know, both sets of comments really interesting, really lots of food for thought, and I'm sure we can only scratch at the surface at the depth of things that one would really like to be able to get at. I mean, I liked your point, Arnab, about can we sort of disaggregate some of these big impacts, and to a certain extent we can disaggregate it by the variables that we've got. And so, for example, we're able to show in the box plots the specific types of services that people are using more and less of. But obviously there are also a lot of black boxes. And I think, you know, what I would really like to do more work around is understanding the mechanisms by which the higher public health expenditure is finding its way to making people use the public services more. I mean, the assumption might be that it's improving quality across the board, and we see changes in treatment-seeking behaviour at all levels in that box plot, and that not only is it improving quality, but it's improving quality in ways that people can see. because otherwise it won't motivate changes in their health-seeking behaviour. And it does seem almost too good to be true, I would agree. I mean, we were quite, impressed by those results ourselves. And, while I do believe that it's highly likely that what you need to do to control the informal, unqualified, potentially dangerous private sector is to have a decent public sector that people can go to instead. I do think we need to understand a lot more. So I think it's an important first cut at this question. I think it surprised me a bit by how clear the answer was and how big the answer was. But I think we do need to drill down more, and I think we need to think about how to do that. I'm not sure exactly what methods we might have available to answer those questions, but we certainly agree with you. We'd like to think about it. And then just to revisit the gender stuff, which I do think is really interesting, and I'm just going to reiterate what I think what the results are and how I interpret them, and then maybe we can turn the tables back to everybody else to say, is that how you interpret them? When we look at the three conditions, which is not men, women, and children, but adults, which were both men and women in the chronic respiratory condition, women and children, there are huge differences. Let's just consider the gynecological condition versus the chronic respiratory condition comparison first of all. It shows everything that you would expect to see in say a men's condition versus a women's condition. Women getting less care, women getting more care in the public sector and less in the private sector, and less money being spent. But when we compare women and men who have the same condition, chronic respiratory illness, then we see almost identical use of the health system, the same amount of care, the same being spent, more or less the same distribution between the public and private sector. Now, does that mean that there's no discrimination in the way that men and women use the health sector in India, because when they have the same condition, they get the same? Maybe. Or does it mean there's huge discrimination, but it operates in the form of discriminating against conditions that only women suffer from? Or does it even say the opposite? Actually, there's pro-women's condition discrimination, because the reason there are fewer visits and lower costs is because they get an adequate response in the public system. As you were saying, I can't remember which of you made the point about, the public system is most focused on women and children. So when a woman has a reproductive system complaint, it's actually dealt with few visits, low costs, effectively. Either any of those interpretations is possible of the data that we have actually. And it's another area where it would be good to really drill down and understand it better. But I think the really interesting result is in some ways the negative result, that women and men use the system almost identically when they have the same condition. For me, that is very eye-opening and not I think what we might all, perhaps some people would have expected that, but certainly I didn't. In reading the Indian literature, I wouldn't have predicted that based on that. And then just your last point, Arnab, about what kind of private providers were these? We realized early on when we were constructing our survey that getting a clear answer to that question from the people who've used one provider or another was going to be impossible. People don't know what qualifications the person they go and see has. And of course, they're deliberately lied to and confused. So people will put false certificates on their wall and all sorts of things to convince you that you're going to a proper provider. So there's no way we could get by talking to users a good sense of what was a formal provider and what was an informal provider. So we take the view that the vast majority of private providers are informal, and therefore that seeing a reduced use of private is likely to be an increase in the sort of rationality of care. But if there are good ways around that problem, how can we find out which kind of provider people have really gone to? I'd love to hear more from people. And then Devaki, I think most of your comments are probably for Sumit, because they drill down into the details of interpretations and experiences that quantitative data don't really help you get at. But I will say a little bit about what you're saying about the R-squared numbers. And first of all, to make very clear that I don't really make claims to being an econometrician. Other members of our team did the econometrics, and I'm reporting them, and on the whole feel I understand them, but certainly I'm not going to be able to stand up to a good econometrician's interrogation on them. What I would say is that my understanding is that R-squareds at sort of between 17 and 32, or 0.17 and 0.32, are not particularly low for this kind of work. So they didn't cause me to think, oh, we've got a problem here. Probably 0.17 is a little disappointing. I think 0.32 is fine. Does that explain why we're getting such different results for the different models? Is it to do with, you know, a kind of level of variability of behaviors that, you know, obviously to get very high R-squareds, you need to have very well-behaved data that, you know, do things very precisely in response to changes in one variable on the other. Maybe. I'm not very sure what it means, to be honest. So having said I'll answer it, I think I'm just going to answer it by saying I'm not very sure. So Sumit, I think I'll hand over to you for all the tricky stuff now.
Thanks, Barbara. I'll respond to two questions which I picked up, which I thought could be answered together. So doing the easy stuff, if you may. Arnab's point and also Devki's point somehow about the focus on public spending, the case that we made through our secondary analysis, and that is somehow reiterated in the qualitative work, that it is important to focus on the close to community primary care services, because they determine the direction in which people will go. They determine the path down which people will ultimately travel. And the finding that people want to be able to have reliable, trustworthy, reasonably priced services close to their homes. So, but then is it a bottomless, the idea of the bottomless pit, but there's something more to the idea, right? It is not just about the 100 rupees extra. What is this service like, even if we provide it to them? So the argument here is that the financial allocation will make a difference. That's what the secondary analysis shows. But people are looking for more. People want more. It needs to be, as Devki was pointing out, respectful. In our data, there was a saying out of Uttar Pradesh that kept coming back: "Sunwai honi chahiye." People said, we should be heard. We should be treated with dignity. So this is the next frontier. This is allocation of resources is necessary. It will move people. We know, evidence shows, move people to the public sector. But if the services that are provided are not responsive to the needs and expectations, basic needs of being treated well, being treated with dignity and respect, this won't work. So we need a whole toolkit, whether it is related to accountability related approaches, whether it is related to other approaches, to get the public services to become responsive to the needs and expectations of people. Is something that needs to be found out, needs to be tailored to the context, different requirements in the tertiary, different requirements in the secondary, different requirements at the primary care, I would argue. So this is something that we all need to tackle. And sticking with that, Arnab's point about, and also Devki's point about, if women are, if the whole public health services are focused around maternal and child health, why are women not getting what they are supposed to get? Our finding was the system is providing not what the women are looking for. The public health services are providing what they have understood women need to be given. And maybe that is essential and necessary, but women look for more. So the system is falling short in that sense, and it needs to be revisited. There is a there's a whole lot of psychological counseling related need. In medicine, we would call that somatization of the illnesses that we have, the psychosocial aspects of it. But it just illustrates that we need to move away from what we've talked about endlessly, a biomedical focus in primary care. We need so much more than just that. And all that links to what do people do, where do they end up going, whether they experience impoverishing events, and so on and so forth. So 2-3 questions and answer that I've attempted to roll into one, Sapna. I'm sure I've missed others, but you'll definitely point them out to us. Over to you.
Great. I am going to do 2 things. Devaki and Arnab, unless there's something burning, I will come back to you after we go to the participants, because there's now a lot of questions. Barbara, I'm going to start with you. There's some questions, short ones, I think, on the methods that I think you've already seen. One around the unit from Vikram Patel on the unit of analysis for the analyses on public health expenditure. And those are actually from the NSS, not from the survey. So I think that's a quick one. And also Priyananda had a question on the results on the public health spending. And is it linear or non-linear in terms of what the increases suggest in terms of the implications? If you could go to those, and then Sumit, I'll come to you. There's a bunch of questions on the pathways.
Okay, as you say, Sapna, the first question from Vikram, the data set is the NSS, and therefore the number of units is the number of states that exist in India, not the number of states that we visited. So hopefully that's a quick clarification. Priya, we don't know whether it's linear or not. We haven't tested non-linear models. It would seem highly unlikely that it would be sustainable at that kind of level, that such small increases in expenditure could continue at all levels of expenditure to reduce use of the private sector to that extent. It would be perhaps interesting to have a look and see if some non-linear models fit the data, but we haven't done that. That's the 2 that you gave me, Sapna, quickly dealt with.
Thanks. And then there's 2 questions that are about the sort of the port of first call in terms of the role of ASHAs. But with that, Sumit, if you could also respond to the question that we have a little lower down that I think you've seen around the role of Ayush providers in terms of thinking vis-a-vis care-seeking pathways. And I think this is something both Arnab and Devaki were keen to hear about as well. So the port of call, and then where we see different types of providers in the pathway.
Right. I'll begin with the Ayush providers into our thinking. That's Anna's question. In the villages, there is doctor and there is doctor, and that's it. People are not making a distinction between whether I'm going to a Ayush. It's a very urban thing, an Ayurvedic or a homeopath, and so on and so forth. And this qualitative work and most of the surveys in rural settings, all the providers, no matter who they are providing all kinds of medicines. If we ask them, what do you identify, and we did not go about asking it, they might label themselves as, yes, I'm a Siddha practitioner, or I'm an Ayurveda practitioner, or so on and so forth. But when you look at the medicines that are stacked up in their racks, you've got everything. You've got streptomycin injections in somebody who's got BAMS written on his door, steroid injections stacked up here and there. So the identity question is a question that is very complicated. It's also very political. It's also very ideological. So we haven't really gone there in that sense. But what role might they play in the care-seeking pathway? From what I see, from the villages that we went to, 20-odd villages, multiple visits over many days, many weeks. This is opportunism at its best. Because we don't know the credentials, the motives and motivations of anybody, We know that people are out there to exploit and make a quick buck and continue making a quick buck for a long time. It becomes difficult to say, okay, somebody's black, somebody's white, somebody's good, somebody's bad. I think providing good quality, reliable primary care, if it can somehow be organized to the private sector, wonderful. If it needs to happen to the public sector, that's the part that seems to solve things. Sapna, there was another question you said?
There was a question on the role of ASHAs in terms of the first point or port of call, if you found that. And also, while you're here, there's also a question in terms of the decision making within the household.
Yes. So let me come to the ASHA question first. We haven't examined the question of ASHA, but I've got ongoing work on ASHAs in India and with CHWs in other parts of the world, community health workers in other parts of the world. Curiously, ASHAs were absent from people's responses consistently across all study sites. ASHAs were not part of the conversation. It has probably something to do with the focus on chronic breathlessness and also on acute respiratory infections and so on and so forth as part of the survey. They were also relatively absent in the conversations around women's conditions, actually. In some ways, I'm not surprised. The whole ASHA program is organized around performance-based, indicator-based remuneration of ASHAs, and they respond to those initiatives. It is on record, and I hate to say it here, we have put ASHAs on a pedestal. A whole lot of people in the development world are out there to save the ASHA. ASHAs, as we have written in our recent work, are really smart operators. They are calculating, they are thoughtful, they are intelligent women, and they are playing the game. They are not in the mix here, not because they don't want to. I'm sure they could play a big role, but the way things are organized at the moment, they are not part of this conversation. To the other question about decision-making within the households, we are writing a separate piece about it. There is some really fascinating stuff emerging out of how decisions are made within households, how resources are allocated within households. And to give a short answer, it varies across caste lines. It varies across economic lines. In lower castes, we've seen that the decision-making is quite equal. Again, it is borne out in earlier literature on different sections of Indian society being more egalitarian and more gender equal and so on and so forth. The resource allocation across genders within households, we've seen that people have outright rejected the idea, dismissively, almost dismissively, saying, what are you talking about? Which world do you come from? We don't discriminate if it's a woman or a man in the household. But we recognize as part of the qualitative work that some of it is performative. They are performing for us as researchers. So it's possible that it's not true, but the survey findings seem to suggest, as Barbara has rightly pointed out, that the answer is a little more nuanced.
Thanks, Sumit. Barbara, I'm going to come back to you for two last questions before turning over to Dr. Gupta. There's, and I don't know if you can answer these quickly, but there's a question from Rajiv Sadanand about the role of the government in terms of including, for example, COPD into the package of NCDs. So this is talking about expanding the primary healthcare package. And with that, there's a role from Vishnu, question from Vishnu Vasudev about the role of government as a sort of perhaps a advisor on trustworthy sources of care, or if we have any insights from the work, and I don't think you do yet, except from the DCE, on what people consider trustworthy. So if you could take a shot at that, then I'll turn to you, Dr. Gupta.
Sure, thanks. So on the question of the role of primary care, it seems to me that this is something that we're calling for globally in many contexts where primary care has responded to the demographic situation that it faced in the 1970s and earlier, where nearly the whole population was under some quite low age, where reproductive health problems and infectious disease were the problems that were affecting everybody. And primary care systems just about everywhere haven't really successfully shifted from that too much. So it's not a surprise to see that of the three conditions, it's the women's gynecological conditions that were primarily, were predominantly going to the public sector, because that fits with a profile of the public sector dealing with those kinds of conditions, but not with respiratory conditions. Certainly not for adults, acute respiratory infection in children, perhaps. And therefore, I think that it is absolutely fundamental that one of the biggest issues facing that we face in this situation is trying to figure out how to get over the constraints to really changing the mindset of primary care providers to recognize that they need to embrace adult conditions, chronic conditions, and that they need to be that first point of call that will help people navigate the system and avoid impoverishment. That we see perhaps in that picture of people who use the public sector first getting better outcomes probably from the system than people who use the private sector first. There are so many questions in there that for all we are emphasizing the policy implications of this, I think we do have to recognize that there are a lot of unanswered components in what we're arguing, and there is a need for a lot of further work. But that is where I think primary care reform is aiming to go in India, and I think it's the right direction. And trying to think about how to help policymakers make that direction a success, where in so many countries that hasn't really happened despite good intentions, really important. And then on the trustworthiness question, I don't think we have an answer to what's trustworthy, but what surprised me, perhaps, to a certain extent anyway, is the extent to which people responded in the qualitative work, and Sumit might have more to say about this, by recognizing that they were using approaches they were seeking care from untrusted sources. They knew these people weren't trustworthy, but they didn't really have too much choice. And I see Devaki nodding, because it's obviously people with the most limited set of choices who are stuck with having to use the untrustworthy sources. So I'm sure it's true of the migrants and the homeless and the internally displaced and so on, populations that you've studied. And it was true of poorer people in our study too, including that great quote Sumit gave us about, for people with money, they've got options. For us with no money, we try what's available at what we can afford, and then we trust to God. In other words, if that doesn't work, we're done for. And there's huge awareness that the places they're going are risky, untrustworthy, quite likely to lead them in the wrong direction. And it's because of that I'm a bit skeptical about Vikram's suggestion about the sort of call center, the sort of government call advice stuff, because it's clear what they'll advise. They'll advise, first of all, the public system, because it's very hard for the public system not to accept that the public system hasn't always got everything it's supposed to have. So it'll direct them to public facilities that they know are always out of drugs, or the staff don't turn up, or whatever the issues are in those public facilities. So then it won't be trusted, because it won't have that level of local knowledge that they have. And it will tell them to go places they can't afford to go. And it will tell them not to go to the only places that they can afford to go. And so in the end, you'll end up with people just thinking that's a waste of time. Where I think public sector needs to step up and be trusted, and I think we've emphasized this throughout, is in making sure that those close to community, publicly funded places work and give people the right advice, are respectful of people, are kept well stocked. I mean, I believe being out of drugs is not a major problem in the Indian system as it is in some other systems. So it's mainly about the interpersonal and availability of skilled staff that people confront. So I'm not convinced, especially in these rural settings, that the majority of the qualitative work took place in that kind of ring up to get advice approach would work, perhaps in some urban areas, and especially where public services are better. And we'll see more of that, hopefully, in Tamil Nadu and Maharashtra when we get there.
Great, thank you so much. In interest of time, I'm sorry, there's a couple of unanswered questions that Sumit and Barbara, I hope you can do in the chat, but I'd like to turn to Dr. Poonam Gupta for your closing remarks on the entire study. And since I'm not going to come back, I'd just like to give a big thank you to all of the panelists and the participants for being here. And I suspect there'll be lots of follow-up conversation. But over to you, Dr. Gupta.
Thank you very much. Thanks, Sumit and Barbara, for nudging me out of my comfort zone and to ask me to give a few comments. And my escape route was that I'm a macroeconomist. What do I know about health? And I was told, bring your macroeconomic perspective. So this is what I'm planning to do. And I'll also make a couple of observations on the study. And to the extent that it's useful, please consider those. Thanks also for including NCR as a partner in this study, which we were very, very happy to do. So let me relate these broad findings to a couple of things that I have been working on. One of these is on state level convergence of economic outcomes as well as social and developmental indicators. So in this ongoing work, what we are seeing is, and we are looking at the data from 1991 till 2018-19, there is evidence of divergence when it comes to economic outcomes. So income levels per capita is diverging in the sense that richer states are still growing faster, which is interesting. We have some results on the second order effects here, which is that the pace of divergence is slowing, but let me not come to that. But quite hearteningly, what we also see is that there is convergence when it comes to broader indicators of well-being and developmental indicators, which include education and health and other indicators such as financial inclusion, physical infrastructure. When I say health, we are looking at a few limited indicators. These are about longevity, child mortality, stunting, etc. But we see definite convergence there. Where we don't see convergence, interestingly, is in the allocation of capital to poorer states. So whether it's through FDI, whether it's through bank credit, we do not see any convergence happening there. There is divergence. But overall, the takeaway that I have is that economic forces are what they are, but public policy is playing an important role in bringing convergence in overall well-being, which relates to the work that you just presented, the role of publicly provided health services in ensuring convergence in multiple indicators of well-being. The other observation that I have is from my work on what I call macro monitoring. In this work, you are constantly on a weekly or monthly basis, you're looking at indicators of economic activity and you're thinking about the growth dynamics. Along with that, you're also looking at sustainability issues. When I say sustainability, you're looking at fiscal sustainability, financial sector sustainability, etc. On that, and again, it relates to the work that was just presented, including an instrumental variable that was used, which has to do with India's fiscal deficit. So India has been an outlier for many, many years when it comes to the level of public debt and deficit within emerging markets. And India has become an even more indebted country during COVID. So its public sector deficit, fiscal deficit increased to double digit. And currently its public debt, including state and the center, is at 90% of GDP. And under most assumptions, it's not likely to go down rapidly in coming years. It may remain stable or it may decline very, very slowly. So the implication it has is that India currently spends nearly 5% of its GDP in paying interest payments on this publicly held debt. Again, the implication of that is that it's space to spend further on education and health and other such activities remains very constrained. So currently 5% of GDP that is spent on interest payments is more than what it spends on its entire capital spending by the government, state and center combined. It's almost twice as much as it spends on education or health. So the question in my mind is, absolutely, I agree, we need to spend more on health, but where would this room come from? And there are only a few options, and there are trade-offs associated with those options. Should India spend more by borrowing more? And if so, from where? And can it afford to increase that interest payment to GDP ratio? Should it spend more on health and education and other worthy activities by diverting resources from other uses? And if so, which ones, and what would be the political economy of that? The other is spend better on health, right? So just get more bang for the buck. And perhaps the answer has to be in all of the above. So I guess, the findings are absolutely very well taken. But when it comes to public policy, I think somebody has to think about these next level of questions as well. Where is the money going to come from? And how do we make it function better, our existing public finances? A couple of other observations that I have in the study is that I didn't see actually any mention of the quality of services provided by public sources or private sources, and what role do they play in health-seeking behavior. On that, actually, I was also thinking about, also looking into the budget constraint that I talked about. How does one make these publicly provided services to be more progressive? Is it at all possible to choose certain states, certain districts, and perhaps even certain households to get the most out of what the state can provide? And a related question is, do publicly provided services, do they offer any kind of competition to the private providers, in the sense that overall quality improves when there is just either the presence of publicly funded services or better than that, well-functioning publicly funded services? So these are some of the questions in my mind, but overall, I really enjoyed this study a lot, and I look forward to its completion and extending this service, this work to Maharashtra and Tamil Nadu. Thank you, and I'll stop here.
Thank you very much, Dr. Gupta, and to everyone. Again, we are at time, I believe a couple of minutes over, apologies. But thank you again, Barbara, Sumit, Arnab, Devaki, Dr. Gupta, for being here with us, and we look forward to continued discussions. And I believe Shubhangi's put in the chat the website and all, and if people want to write to the authors, please do. So thank you all again, and have a great day.
Thank you, everyone.
Thank you.
Thank you.
Thank you.